Thank you, sir. So the keynote address has already been given by sir, but once again I want to wish Happy Doctors Day and a very good morning, ladies and gentlemen, the galaxy of intellectuals, Your Excellency, distinguished guests, and esteemed delegates. How different is this morning? It's my privilege to be the moderator for the third Endovascular Management India CME come live workshop on varicose vein, deep vein thrombosis, venous ulcer disease, and peripheral arterial disease in this city of joy, Kolkata. I, Shanu Thomas, and on behalf of this organization, would like to extend a warm welcome to this August gathering. We do appreciate for taking your time off from this busy schedule. This workshop is dedicated to advancing our knowledge and skills in the field of healthcare. So we have an exciting day ahead of us, filled with packed, informative sessions, engaging discussions, and even opportunities for networking. This workshop aims foster collaboration, share insights, and explore the latest advancement in this field. So before we start, let me add an inspirational quote from Henry Ford, the founder of Ford Motor Car. Coming together is a beginning, keeping together is a progress, and working together is a success. If everyone is moving forward together, then success takes care of itself. So, not wasting any more time, as Sir has already briefed of today's schedule, we will start with the first plenary session. So, I would like to call upon the chairpersons for the first plenary section, Dr. Roy Varghese and Dr. Malay Patel, to chair this session. And our first speaker for this section is Dr. Jayanta Pal, who will be giving us an insight on the pathophysiology of varicose veins.
Good morning, ladies and gentlemen. Just forget all the nitty-gritties. Words I would like to say. To cut the long story short, all of you know who is the gentleman to the right. He is the person who brought me first to the city of joy about 13 or 14 years back. I call him Bhaskrendu Da, not Krishnendu Da. What should I call you, sir?
Whatever you feel like.
Okay, with this permission, I'll start. First and foremost, opening remarks, I will not waste much time, is that we have a lot of sponsors from the industry here, and also some of the sponsors are individuals. Most of us, national faculty, not most of us, all of us have come here on our own money and our own time. And I appreciate the industry for taking this much of pains in this difficult financial time. But as the MC, Master of Ceremonies told, keeping together is success, and we'll continue the journey. Thank you so much, all of you pharma guys who are here. Jayanta, please start off.
Before we start, I would request Momita to please give the bouquet as a token of love. Dr. Roy.
No, please. Give it to him.
Thank you. We'll move on to the sessions.
Very good morning. Without knowing the anatomy and physiology of lower limb veins, it's very difficult to go to the next level. What are the diseases and how it could be managed. So this is the first session, and there is another reason why it is the first session. Because I know most of the delegates will come little late, so if I made any mistakes, so people won't be able to realize. So that's why it's kept in the first session. So leg veins and its anatomy and functional physiology is our first topic, and we have to understand a little bit of venous anatomy and how diseases occur. Until unless otherwise, we won't be able to provide the proper diagnosis as well as the proper treatment. So grossly, these leg veins are divided into two segments. One is the deep compartment, it is the underneath of the fascia, and another is the superficial compartment. So veins belonging to the deep fascia, it is the deep veins, and above the fascia, below the skin, it is the superficial compartment. And we have accordingly deep veins, superficial veins, perforating veins, and communicating veins. Perforating veins is the veins actually communicating the two systems, superficial vein and deep veins. And the communicating vein is communicating of two different veins of the same system. Either it is in the deep system or it is in the superficial system. Little bit of gross anatomy to microscopic anatomy. Vein wall composed of 3 layers, tunica intima, media, and tunica adventitia. We have to understand a little bit of valve. It is made of intimal layer, have bicuspid structure, and support unidirectional flow. Valve has another role because it actually compartmentalizes the whole length of vein to distribute the pressure. Otherwise, if we can remember the class 11 or 12 physics, that pressure at any single point, it is the HDG, H is the height. So it basically segregates the whole length of vein in different segments, so height is adjusted. So that's how it is very important. It is just quick recapitulation. External iliac, femoral vein, popliteal, then posterior tibial, fibular, and anterior tibial veins. It is just the same picture in a different. Long saphenous vein, it is the most important vein because we will be dealing with varicose vein and lot of things for the veins. So understanding the anatomy of the long saphenous and short saphenous vein and its course is very important because we have to select a lot of things from starting from the puncture side to ultimately delivery of the energy or glue, how and whatever we want to treat. Dr. Rahul Jindal will speak about it in depth, what are the possible treatments and how it can be done in a fantastic way. So it starts with the medial malleolus and ascends up, and ultimately it inflow is going to the saphenofemoral junction and goes to the deep vein. So there are 2 valves, one is the junctional valve and the pre-junctional valves. So it has few anomalies, we have to know this. One anomaly is it can be terminated in a different way and drains from external pudential, superficial, epigastric circumflex just before the SFJ. Duplication is possible in 1% of cases. It can have accessory veins. There are anterior accessory, posterior accessory, and superficial accessory GSB is possible. Every patient don't have all the things, but some patients can have any of the combinations. That is important, we have to know. Next is the short saphenous vein. We encounter the problems with the long saphenous vein more, short saphenous vein less in incidence. But if it is short saphenous vein, it is more difficult to treat because puncture technique will require more skill and training to enter the short saphenous vein. A quick recapitulation of the anatomy. It originates at the lateral foot, passes posterolaterally to lower cuff and then midline in upper cuff. It drains popliteal vein just above knee, saphenopopliteal junction is almost 66% of cases, and posterior medial tributary to GSB, and sometimes it directly to GSB. There is chances of 4% duplication of short saphenous vein. We have perforating veins. There are few named perforating veins. We are not going into the details of the named perforating veins. It actually connects both the superficial system and deep system. How to diagnose varicose vein? It's since our college days. It's starting from the clinic history, clinical examination, and the investigations. In today's world, it is gold standard investigation is the colored duplex. So that is basically a stethoscope for all vascular guys. Those who want to do any kind of vascular procedure in today's world, it's just actually a stethoscope to them. So it is the most important instrument without which we are just blind, we can't proceed actually. There are venous return from leg to heart. Yes, there are valves, but there are also 3 important muscles and muscle pump actually. It is the ankle pump, calf pump, and thigh pump. Without understanding these pumps, no compression device can be advised or compression device can be recommended for the treatment of chronic venous hypertension. We have a separate session only for compression. Dr. Roy Varghese will cover this pump mechanism and how compression garments and compression stockings and other compression devices help this venous return and control of chronic venous insufficiency. So we are not going into the depth of pump physiology. Another important aspect of venous disease is called May-Turner syndrome. If you go by the anatomy, so we can see vein actually can be compressed by artery. There are many locations. We will discuss about its treatment and how to diagnose what are the presentation of this kind of patients in depth in the coming sessions. We are not going into the details. That's all for the basic anatomy for the day for the next session so that we can understand the disease process, management, and the treatment. Thank you very much.